my pleasure to welcome you all to our ECG round. We have three presenters, Dr. Yusuf Adarat from the USA, Dr. Fathi Idris from the USA, and myself, Khalid Abuzgaya from the UK. The session today is focused on ECG interpretation, and we're hoping this will be an interactive. So there will be lots of ECGs and lots of questions, and hopefully every ECG and every case will have a message with regard to troubleshooting ECG interpretations and management. We have a mixture of ECG. We are aware that the audience is a mixture from student to cardiologist. So hopefully there will be cases with interest to all levels. We're hoping you enjoyed the session today, and I encourage you all to ask questions, actively take part in answering questions and addressing any questions or answers. We welcome all of your comments, so please send any comments to us or any questions. There is no such a stupid question, so please feel free to ask any question. So without any further ado, I will introduce our first speaker, Dr. Yusuf Adarat. It's a pleasure. He's a good friend of mine and colleague. And just before we start the presentation, all of these ECG, almost all of them, are from our practical experience. So just to share with you our clinical experience, so hopefully you'll find it useful. Yusuf, the floor is yours.
Shukran, Khalid. Assalamu alaikum. Thanks for joining us today. We really appreciate the time taking out of your busy schedule to join us. We'll try to make this session as useful as possible. And like Khalid mentioned, please try to ask questions. If you have any, any questions you'd like to ask, please write it down or raise your hand, and we'll be glad to answer the question and have a really useful discussion for all of us. So we'll start by with the cases. So we'll have EKG, of course, and with a really short scenario, and then we'll have multiple choice questions. So there's 3 or 4 different choices. And once we're ready to answer the question, you'll have 30 seconds to answer the question. So once we have the poll ready, go ahead and vote. So I'll start with the first question, which is a 14-year-old female who's been having history of palpitations, presented with this EKG. Based on this EKG, what is the most likely mechanism of tachycardia? And what's the reason for her palpitations? So choice number 1 is it AV-NRT, which is AV nodal reentry tachycardia, AVRT, atrial tachycardia, or she has inappropriate sinus tachycardia. So I'll pull up the poll for you, and then you'll have 30 seconds to answer. Okay. So I see 9 out of 15 answering the question. Please feel free to answer whatever you think. Even if you're not sure, go ahead and put the answer, because it's an anonymous voting, so no one will know who's going to answer. So, here 28% is answering AVRT. Most 33% have answered AVRT. So we have most people voting for AVRT, though it's close. Let's go back to the presentation. So the right answer is AVRT. You can see that the 12-lead EKG shows a short PR interval, and there's a delta wave. You can see how short the PR interval here in V1 and all leads, very short PR interval, and you can see the slurring of the delta wave. So that suggests that the patient has Wolff-Parkinson-White. This is a Wolff-Parkinson-White pattern. Patient has palpitation, which is symptoms that the patient may have a Wolff-Parkinson-White syndrome. So the most likely mechanism of the arrhythmia is AVRT, which is AV reentry tachycardia. And I'll show you the slide. So basically what AVRT is, and which is basically the manifestation of an accessory pathway. Those patients have an accessory pathway, which is also called an AV nodal connection, or not sorry, AV atrioventricular connection, which is basically a muscle fibrous connection between the atria and the ventricle. You can see here in this example that the atria and ventricle have a connection which bypasses the AV node, and therefore you can have basically three different types of arrhythmias. You can have what we call as in this example, antidromic AVRT, in which the beats go through the accessory pathway antegradally and up through the AV node, leading to a wide complex arrhythmia. The other example, you can have pre-excited AFib, in which you have atrial fibrillation in the top chamber, and that can conduct fast through the accessory pathway, and this may lead to sudden cardiac death and ventricular fibrillation in that patient. And then, which is the most common presentation, is actually C, and or the most common arrhythmia. It's which can see about 80% of all tachycardias in patients with AVRT is an orthodromic, in which the beat goes down through the AV node and up to the accessory pathway, leading to orthodromic AVRT and a narrow complex tachycardia. So basically, AVRT has different flavors. You can have.
Yusuf, can I interrupt you for a second?
Yeah, sure.
We just have a few comments that say, could you just raise your voice? They can't hear you very well.
Is this better now?
Absolutely, very good.
Okay, so I'll just summarize what I've said. Basically, you can. The answer is AVRT. In this patient, which has an accessory pathway, based on the ECG finding, which shows a delta wave short PR interval. There's three different possibilities with AVRT. Either the most common is C, which is the orthodromic AVRT down the AV node and up the accessory pathway, leading to a narrow complex tachycardia, which represents about 80% of AVRT. Then you have antidromic, which goes through the accessory pathway up the AV node, and thereby causing a wide complex tachycardia because it's going down the accessory pathway. Then the other manifestation could be pre-excited atrial fibrillation, in which the patient has AFib, leading to irregular wide complex tachycardia, and those patients are at risk of having ventricular fibrillation as a result. So the answer is AVRT. We'll go on to the next question, next case. Which is there's a 12-lead EKG, which looks like a narrow complex tachycardia in a patient who's hemodynamically stable, presents with tachycardia rate is 230 beats per minute. So what is the next step? Seeing this EKG patient presenting such a presentation, so would you do number one, electrical cardioversion, IV adenosine, number two, number three, IV fluids, or number four, echocardiogram? I'll go ahead and pull up the poll. And please go ahead and vote when you're ready. There we go.
So Yusuf, just to, this is a hemodynamically stable patient, is that right?
Yes, I missed this stable. So it's a hemodynamically stable patient. And if you'd like to, you can click on the EKG to zoom it and look at it in detail. So look at it Okay. we had about 50% of the audience answering. IV adenosine, absolutely right. So patient is hemodynamically stable, not a complex tachycardia. I completely agree. Would give IV adenosine to see if the tachycardia terminates or not. So let's go back to the.
Yusuf, for some reason we don't see the result. Can you share the result with the audience so they know what was it?
Okay, I think I closed it. Let me pull.
So
I closed it.
share results.
Yeah, most patients, not most patients, most have answered the right question, which is IV adenosine. About 60% voted, and I think there was only one who voted IV fluids, but the rest voted for IV adenosine. So, IV adenosine was given. What did the IV adenosine do? This is an EKG that was we got after IV adenosine was given. So, did it terminate the tachycardia? Number 2, affect AV nodal conduction, or number 3, no effect. So, go ahead.
Maybe leave this EKG for a few seconds, Yusuf, so people can look at it before you open the poll. And we start now. Maybe the timing. Go ahead and open the poll now for people to vote.
Okay. So we have 64% of all the audience have participated. 11 people participated, and the answer is most people have voted for affect AV nodal conduction, which is the right answer. The arrhythmia did not terminate. So the right answer is affect AV nodal conduction. Basically, what adenosine did is it's blocked the AV node. That's what adenosine does. And you can see that the conduction became kind of 2-to-1. There's a P wave here. The arrhythmia did not terminate. So the differential diagnosis could be an atrial tachycardia, though it's a little bit faster on atrial tachycardia. The other possibility is atrial flutter. And the first EKG showed possibly an atrial flutter with 1-to-1 conduction. So again, the right step to do in a patient who's hemodynamically stable and a narrow complex tachycardia, that's the take-home message, is to give IV adenosine to try to, it has a diagnostic, basically purpose, and the other thing also as a therapeutic option in patients that have AV nodal dependent arrhythmias, it can terminate the arrhythmias, like AV NRT or AVRT, the arrhythmia can terminate. Okay. Next question, okay, case number 3. This is a 51-year-old male with palpitations. What does the EKG show? So the options are number 1, atrial fibrillation, number 2, atrial flutter, and number 3 is atrial tachycardia, or none of the above. I'll give you a few seconds to look at the EKG, and once the polls are pulled, you can actually click on the magnifying glass and see the EKG. Can you all see the summary there?
Yes, I can see it.
Okay, good. So basically, 51-year-old male palpitation. What does the EKG show? So we have the people answered atrial flutter, 25%, and none of the above, 12%. Now the right answer is none of the above. This is kind of a tricky EKG because if you look at the EKG closer, I mean, it's regular, okay? So kind of atrial fibrillation is ruled out. So atrial flutter, the flutter waves are not really typical. I mean, they really look like they're all over the place. It's and you can see see here this part. There's a P wave here. This is actually a patient who I think has Parkinson's, and there was some tremors, and that led to this picture, this EKG. So the right answer is actually none of the above, and it would be an artifact. This is an artifact. A lot of times the computer analysis on the 12-lead EKG would say atrial flutter because it looks at some underlying waves, F waves, and it's regular. So it basically interprets that as atrial flutter. But and the other thing is other than the morphology and how the waves look like, you can see. I'll get the pen again. You can see that the F wave to F wave or the P wave to P wave duration is very non-physiological. I mean, there's no way that even flutter would be that fast. So this is a artifact. So next case, case 4, 69-year-old male with syncope and palpitations. What is the next step in this patient's management? So once you look at the EKG, the answers would be number 1, does the patient has a left bundle branch block and needs a pacemaker? Number 2, EP study and ablation, or number 3, none of the above, simply do nothing. So please take a look at the EKG, and once you're ready, you can go ahead and vote. Okay, so we have about 60%, almost 60% of the audience have answered participated in this survey. So the question, it was a 69-year-old male with syncope and palpitation. What is the next step in management? You can take a look at the EKG by clicking the magnifying glass. You'll see a white complex, sinus rhythm white complex. And then you can also appreciate in this EKG that the PR interval is kind of short, very short PR interval. I'll go back to my presentation. Can you all see my PowerPoint back up? Okay. So there is, see the P to R interval is really short, and you can see the slurring again. I'll do that. See the slurring of the delta wave. I mean, this could be tricky. I mean, someone could think that this is a left bundle because this is basically an accessory pathway that's a right-sided accessory pathway. So it activates the right ventricle before the left ventricle. So it gives like a left bundle kind of morphology, but it's actually not left bundle. And the way you can tell is that the PR interval is pretty short, and that there's a delta wave, there's slurring. Which is not really seen with left bundle. It looks like an atypical left bundle. So, so the answer is an EP study and ablation for this patient. So we did an EP study. The patient had the right side accessory pathway, was ablated successfully, followed up a few weeks back, doing really well, no recurrences. He was complaining of palpitations, but did well with the ablation of the accessory pathway. So next case, there was a question about what's EP study. EP study is basically we put catheters inside the heart and determine where the accessory pathway is. And then if the patient has symptoms or the pathway is a malignant pathway, can lead to sudden possibility of sudden cardiac death, then we can ablate by putting catheters and using radio frequency energy, we can burn that area. So it's basically, it would be an answer in a patient who has WBW or a narrow complex tachycardia that's suspicious for AVNRT or AVRT. So let's go and move on to next case. Case number 5, 81-year-old lady presented with nausea and vomiting. She was sick. She had ascending cholangitis, but she reported that she's been having some syncopal spells at home. We had to see the patient, and this is a 12-lead EKG. They were concerned that the patient may need a pacemaker. So this is 12-lead EKG. Please take a look. What are the options are, is this AFib? Is this a second degree type 1 AV block? Is this a second degree type 2 atrioventricular block? Or this is a complete heart block? So 41% have first participated. So this is, again, I'm just going to read the question again. 81-year-old lady presented with nausea and vomiting. She has ascending cholangitis, reported history of syncope. This is the EKG. So most people have answered it's kind of second degree type 2, 29%, and complete heart block was 23%. So it's split between second degree type 2 and complete heart block. So I'll go back to my presentation. I'll show you an EKG. So there's a P wave. So atrial fibrillation is ruled out. I mean, you can see P waves here. So that's ruled out. So it's not atrial fibrillation. So then the other option is this first degree. Well, I mean, there's prolongation. There's drop P waves. So it's not a first degree AV block. Okay. So what do? You can see that there's some group beating. Whenever I see this group beating, I would think of second degree. So it's a type 1 usually. So let's go this step by step. So you can see here there's a P wave, though it's actually more in the later part of the T wave of the previous complex. And then if you measure the P to R interval here, it gets longer. So the P to R is longer compared to this one. And then you have another P wave that's in the later part of the QR of the T wave. And you know that this is a P wave because if you look here, the T wave looks a little bit different. So if you compare this to this, you can tell that there's a P wave hidden or as part of fusing with the T wave. So there's a dropped P wave. There's no QRS complex. And then the PR interval is shorter compared to this one. So this is typical for second degree type 1 Winkie-Bach. So you have progressive prolongation, then drop beat, and then again prolongation and then drop beat. So this is Winkie-Bach. This is second degree type 1. In this EKG, you can see that this looks like a first degree, but this part shows a second degree type 1 Winkie-Bach. And the patient has nausea, vomiting, she's sick. So that could be a strong vagal response. We don't typically put a pacemaker just because of this. We observed the patient, she improved, monitored her for several days. She hasn't had any recurrence of no higher degree AV block, and she did well, so we send her home with follow-up. We did think about an EP study at some point, but you can see that she has narrow complex. So anyways, this is a second degree type 1 AV block Winkie-Bach. The findings are not really consistent with Dr. Nahas with complete heart block. When you can see the progressive prolongation and then drop beat, so that goes with at least in this EKG. We'll move on to the case 6. Case 6, this is a patient, as you can see, a wide complex arrhythmia. So what's the diagnosis based on the EKG? Is this ventricular tachycardia? Is this SVT with aberrancy? Is this pre-excited AFib? Is this RV pacing or just simply artifact? So please take your time, look at the EKG, and then we'll go over that. Okay. So 47% participated. It's interesting. There's a split. It's kind of all over the place. It's so 70% answered ventricular tachycardia, 11% answered SVT, smaller percentage pre-excited atrial fibrillation 5%, and RV pacing is 11%. So most people think that this is VT. So let's go back to the my presentation. Then we'll go over this. So this is kind of a tricky one. The main thing is that any wide complex tachycardia can be three of those options. So this is any wide complex tachycardia. When you take a look at wide complex tachycardia, take a second, pause, think, is this VT, SVT, aberrancy, pre-excited AFib, RV pacing, or artifact? And we can rule them one thing at a time. Artifact, it's unlikely. It's kind of very consistent. Does not fit morphology of artifact. So artifacts ruled out. So and then VT, of course, we all worry about ventricular tachycardia. It'd be good to have a scenario. I mean, if you know the patient, what's the patient's history and presentation, then that could help. But I just didn't put that because that might give you the answer. So I just left it there as a kind of spot diagnosis. The right answer is RV pacing. You can see there are spikes here. See, this didn't capture, but there are spikes just before the QRS complexes. And this is RV pacing, and it actually goes with RV pacing. This looks like a left bundle morphology, inferior axis in the inferior leads here. So it's pacing from the RV apex most likely. So this is an RV pacing, and the point that can suggest that, you can see that there's a spike here. There's another spike here. Of course, I know that the patient has a pacemaker. There's a spike here. So this is RV pacing. So it's not regular because this patient is showing an upper rate behavior. So his underlying sinus rate, so he has sinus tachycardia, and his sinus tachycardia is faster than his upper rate. So he's having a winky back. So this patient has complete heart block. His heart doesn't beat on its own, so he has to track the sinus beats, and then he blocks every number of beats. So he blocks every one. So let's see, 1, 2, 3, 4, 5, 6, 7. So every 7 beat he kind of blocks. So this is called an upper rate behavior. That's why it looks irregular. And it's not pre-excited AFib. Pre-excited AFib usually has a different QRS morphologies and complexes, and is more irregular than what we see here. SVT or the Barency is ruled out because I mean, it doesn't look like a typical left bundle. The other thing is that you can see that it's kind of concordant. This is not through his Purkinje system. So it's kind of negative concordant. So this is either a VT from the apex of the heart or RV pacing, and there's a spike. So this is RV pacing. This is how to summarize the whole case. So this is RV pacing based on the presence of the spike. Okay, we can discuss this further later if anyone has a question, but we have to move on to the next case. Case number 7, 78-year-old female with palpitations, normal heart, no history of coronary artery disease, generally healthy lady. She came into the emergency room with this narrow complex tachycardia, and she was given adenosine, which is the right step to do. She was hemodynamically stable, therefore she was given IV adenosine. So the question is, what is the most likely mechanism of the tachycardia? So could it be, is it most likely atrial tachycardia, is it most likely atrial flutter, or most likely AV NRT? So take a look at the EKG, and please, once you're ready, go ahead and vote. Okay, so most people, that's the right answer, AV NRT, and you don't even need to look at the EKG. It was terminated by IV adenosine, which usually doesn't happen in atrial tachycardia, but most likely it's an AV nodal-dependent arrhythmia. So that's the right answer. I think most people got this. So this is an AV nodal-dependent arrhythmia, and the only choice for AV nodal-dependent arrhythmia here is AV NRT, which is the right answer. We can go ahead and stop now. I had some few more cases, but we can maybe I'll just go over the slide just to show this, that patients with AV NRT have dual AV nodal physiology. There's a slow pathway and a fast pathway. And what happens in patients with AV NRT, that a beat gets conducted to the slow pathway and up through the fast pathway, leading to atrioventricular reentry. For those of you interested further, basically anatomically, the slow pathway is located close to the AV node, and the fast pathway, this is the fast pathway located to the close to the AV node, which is this here. And this is the slow pathway, and they're basically inputs to the AV node. And once arrhythmia happens, and you have about maybe 20 to 40% of people have dual AV nodal physiology. Not all of them develop AVNRT, but those who have the propensity to develop AVNRT, a bead gets conducted to the slow pathway when the fast pathway is refractory, and then has the ability to, once the fast pathway recovers, it leads to re-entry, and therefore this short circuiting, which goes around and around and around, leading to a narrow complex arrhythmia.
Thank you, Yusuf, for very nice short cases and snapshot of what you could see in the electrophysiology and cardiology world. I just want, Yusuf, if we could go back to your presentation. I think I want to address a comment by Dr. Salhin and Dr. Sulaiman, I think. If I could go back to case 3.
Case number 3.
I think there was a question about what to do. Do we need to call cardiologists? Is there a way? I think the hint in this ECG for me is your lead. Let me just put my. It's lead 3.
Yeah.
You can see lead 3. You can see it very beautifully. There is a P wave, QRS, very nice flat line. Remember, this lead 3 correlate to your rhythm strip. So this part here, you are in sinus rhythm. So as Yusuf suggested, that this is not physiological, cannot be a flutter wave. This is just too fast. But the clue here is really the lead 3. So this is sinus rhythm. And at the same time as your rhythm strip, it's showing this artifact. And we all know that this is very common in patients with Parkinson's, or if there is any interference with the ECG machine. I think then while we're waiting for questions, please, if you have a question, either you write it in the chat box or you raise your hand. I think someone raised his hand. Dr. Siraj Ajaj, could you give him the speaker, Fathi? So while we're waiting for Dr. Ajaj to have the speaker, there's a question, Yusuf, from Dr. Sagar, I think. How to differentiate between AVNRT and AVRT? Okay.
Good question. Yeah. So the only way, in my opinion, and basically I think also Khalid and Fathi will agree that definitively an EP study to tell for sure and induce the clinical arrhythmia and basically do certain maneuvers during the EP study. But if the patient has, for example, that lady, that first question, that she had a delta wave and a short PR interval, I would of course think of AVRT as the underlying mechanism of the arrhythmia. If the patient has a narrow complex tachycardia and their underlying EKG, baseline EKG shows a short PR interval delta wave, WPW, then that's suggestive of AVRT. If the EKG looks completely normal, it cannot rule out AVRT because the patient may have a concealed pathway by which they conduct retrogradely only and lead to autodromic AVRT. One way, it's on the EKG is if you can see a P wave and the V to A interval is kind of wide, that might be AVRT. If it's really short, you can't see a P wave, I would go most likely with AVNRT, but definitively an EP study. Did that answer your question? Do you have any comments, Khalid, on what I said? I mean,
I think Yusuf it's a question which is beyond the scope of this presentation, because we could go for.
Yeah, we have to. Yeah.
I think it's not easy, but there is a few features which I believe it's if we go through it, it will need at least half an hour.
Yeah.
I'm hoping to address. I'm hoping to address some of these points in my presentations. So I will address few points. But to answer your questions in a very simple answer is, it's not always easy, and as Yusuf suggested that. Sometimes we can from ECG, but most time we have to do an EP study, which is electrophysiology testing. And I'm hoping one of my cases will touch more on that. So hopefully I could answer that question there and then.
في سؤال من باجيلا تقريبا لا narrow complex tachycardia case 1, if it was not responding to repeated doses of adenosine, what would you do? I mean, adenosine does the trick. I mean, it might not be an AV nodal dependent arrhythmia. It could be something else, but it should block the AV node, and you should see like I said, it has a diagnostic purpose and therapeutic. Therapeutic, if it's an AV nodal dependent, it breaks the circuit and the arrhythmia terminates. So we can call it an AV nodal dependent arrhythmia. Then the two differential diagnoses would be AV-RT and AV-NRT. Or you can reveal the underlying by blocking the AV node. You can see an atrial arrhythmia, which could be maybe in some cases atrial tachycardia or atrial flutter. But adenosine should do it. Now, if the patient is hemodynamically unstable, I would cardiovert the patient. But adenosine, based on my experience, adenosine works.
Thank you very much, Yusuf. I really enjoyed the cases. So now we're going to move to my presentation. Can you hear me okay? I think one, if you can hear me okay. Is the volume okay?
Yeah.
Okay.
So go ahead.
Okay.
I can turn myself on. Yeah.
Right. So again, these are short cases. So we have this young patient who we just saw, as you could see from the date, just last year, presented with palpitations, hemodynamically stable. I'll give you a few minutes to look at the ECG, then I'll give you the options. Okay, so this is his sinus rhythm ECG. So I'll give you about 20 seconds to look at this ECG. And I'll go back to the tachycardia ECG before I ask you the question. Okay, so what is the likely diagnosis? What's the likely diagnosis? A, AVNRT, ATAC, AVRT, ATAC, and AVRT or VT. So if we could have the poll now, please, Fakri. Okay, I hope you could all see the results. The majority answered AVRT. A few answered AVNRT, and about 5% chose both atrial tachycardia and AVRT. So I'll go back to my presentation. And I'll go back to the ECG. So all I could see here is tachycardia, regular QRS complex, looks fast. And I just want to show you two ECGs. I want to highlight your V1 and lead 2. So this is during sinus rhythm. This case, hopefully answered question previously was answered, is sometime by having tachycardia ECG and resting ECG, you could be 80–90% confidence of the diagnosis. I have to be honest, not all the time. Most of the time we will need to take the patient to the EP lab to do an electrophysiology testing. But in this case, what we've shown here, during sinus rhythm, you have a nice P wave QRS. Whereas in tachycardia, you have obviously fast QRS. And if you see at the end, there is that notch there. Again, in lead 2, you could see P wave QRS. I'll just show you. And you could see a flat line, then the T wave. Whereas during tachycardia in the inferior lead, you see a QRS, then a negative deflection, then the T wave. So I'm suspicious here, this is a P wave. And over here, I'm suspicious this is a P wave. I'll show you again. And I always, as a cardiologist, I use, if you understand how the electricity and ECG is generated, then it will make your life a lot easier. We all know that I always look at AVL, AVR, inferior leads, as well as the chest lead. For our sinus node, for our normal P wave, any signal going away from the lead will be displayed negative. We know the AVR is toward the right shoulder. So the sinus node is generated here and goes that direction. So it's away from the AV node, AVR. So it's always negative in AVR. But I always look at the inferior lead. So the inferior lead, it should be always positive because it's coming from high to low. And this is what we describe it in the EP field. We say high to low means it's coming from higher up. It should be positive in the inferior lead. For the tachycardia we have in this patient, it's actually AVNRT. And AVNRT, Yusuf mentioned briefly in his presentations. It's a circuit. So any re-entrant tachycardia is a circuit. So you need to have two tissues with two conduction property. One usually slow and one fast. So for normal, we all have as an AV node, we have a component. We describe it as a fast pathway, and a component, we call it the slow pathway. And this is within the AV node. So a normal atrial signal coming from the sinus node comes all the way to the AV node. It activates the fast pathway. And because the slow pathway is very slow, so the fast pathway activated quick and go into the V through the His bundle and then left bundle and right bundle. Sometimes you have an atrial premature beat which comes early, find the fast pathway is already refractory, activate the slow pathway, and it goes to the ventricle, but the fast pathway still did not recover. So you don't have a tachycardia, but you just have an atrial premature beat. The situation where you develop AV NRT is where this atrial ectopic activate the fast pathway. So it goes very slowly. By the time it reaches over here, the fast pathway is no longer refractory. So what happens is your slow pathway will activate the ventricle, but at the same time, the fast pathway now is not refractory and go retrogradely, go back to the A. So you end up with A and V. So the V is manifested by the QRS, and the A is manifested here, which you could see it in the inferior lead, is negative. So the question is, why it's negative? Let me just go back to this diaphragm. So we know that our AV node is situated here, and the A component in AVNRT is essentially a retrograde beat. Means instead of going from high to low, it's going from the AV node back to the right atrium. So it's from low to high. So it's going that direction away from the inferior lead. So you'll have a negative P wave. So the P wave will be negative and almost simultaneous or at the same time as the QRS or just after the QRS. So you could see in AVNRT, in the typical form of AVNRT, you have a QRS, then you have what look like a retrograde P wave, which is a negative deflection in the inferior lead. So if we go back to our tachycardia ECG, you see here in the inferior lead, you have a P wave, QRS, flat line. Whereas during tachycardia, you have QRS, a negative deflection, which is likely to be the retrograde P wave, and then your positive T wave. So this is likely to represent a retrograde atrial activation, what we call a retrograde P wave. And in V1, you could see it positive here. So when you compare it to the resting ECG, you don't see it. So we call it an R prime, which is which is very, very characteristic of typical AVNRT. So if you see the sinus rhythm, there is no activation here, and your P wave is normal. High to low means positive inferior lead. During tachycardia is negative in the inferior lead, means it's retrograde, and it's positive in V1. This is very likely suggestive of AVNRT. And AVNRT means the reentrant is within the AV node. So this is why we call it AV node reentrant tachycardia. And hopefully this will just illustrate the importance of P wave morphology. So when you interpret the ECG, it's not all about narrow, fast, and so you need to look at, can you see the P wave? And usually the two places where I look is the inferior lead. Can I see a negative or positive P wave? And then I look at the SR prime or positive deflection at the end of the QRS in V1. These two features are very suggestive of typical AVNRT. So it's AV node reentrant tachycardia. So I'm hoping this this case illustrates the importance of looking at P wave morphology. And if you see these features, you know that this is likely to be AVNRT. Can you see the ECG okay? I just got a comment. If you write one, just to say yes. Okay, fine. So we'll go quickly through the next case. So the right answer here is obviously AVNRT, number one, number A. So we go to our second case. This is a similar presentation. This is in fact just a couple of months ago. This patient presented to my EP lab in tachycardia, and this is his resting ECG. I'll give you about 30 seconds to look at this ECG. The other thing I want to stress out is it's really advisable when you have a tachycardia ECG. If you have access to the ECG during sinus rhythm, this will be extremely helpful, especially in the first case where we saw that there is this typical feature of AVNRT. And so now I'll give you the resting ECG, and I will just go quickly through the options, and then I'll go back to the resting ECG. So again, similar to options we have in the first case, is this AVNRT? Is this atrial tachycardia? Is this AVRT? Is this B and C? Or is this ventricular tachycardia? And I'll take you back to the tachycardia ECG, and then we'll ask Fathi in 30 seconds to put the questions for voting. Okay, so if we could have the question poll, please, Fathi. Again, you please. I think this ECG is not the correct one you see here, so please ignore that. This is why I gave you more time to look at the ECG. Okay, so as I expected in this case, I'll be honest, it's not very straightforward. We have a split answers between all options, but it looks like atrial tachycardia is the favorite answer. And then there is split between the other options. See, if we go back to our presentations, and we'll go back to our tachycardia ECG. So I'll be honest with you, as soon as I saw this ECG, I could tell this is narrow QRS, It's fast. So it's SPT, so differential diagnosis of SPT. As you all remember from my previous presentation, I always look at the P wave. Can I see the P wave? And specifically in the inferior lead and in lead V1. So in the inferior lead, I don't know if you could see it, but do you all agree there is a positive deflection there? I could see it very nicely in lead 2, as well as in AVF and lead 3. So this is, again, this suggests that our P wave activations, it's high to low. So if I show you this one here, so if our inferior lead is positive, means our activation is coming from high to low. If it from low to high, the P wave will be negative. So this makes AV in RT unlikely, because we know for AV in RT, which is the commonest form of SPT, you have activation of the V through the slow pathway, but the A is activated retrogradely through the fast pathway, this direction, which means your P wave should be negative. However, there is a trick. I said that look at our resting ECG. Always compare your resting ECG with your tachycardia ECG. I don't have any questions here, but I was wondering if anyone wants to write in the chat box what sort of observation they have about the P wave. So I think you clearly see. So Dr. Anas say it's a long PR. I agree. There is a degree of first degree heart block. That's correct. It's biphasic, specifically. Yeah. Okay. See, that's good. Right. So you could see clearly in the inferior lead, there is a broad P wave. The first component is very tall and peaked, and then there is a second component of the P wave. So this would bring me to P wave morphology. And this is the way how I remember P wave. So I just want to see if our drawing will work. So the P wave, this is how I remember the P wave. From medical school, I was told that the first part of your P wave is usually related to right atrium. So in right atrial enlargement, you will have a peak P wave in your lead 2, and also in lead V1, peak the initial part. So anything involved the initial part of the P wave is likely to be related to the right atrium. Whereas the left atrium is usually second component of your P wave. So anything involved the second component is usually related to the left atrium. So in left atrial enlargement, or what we call P mitral, you should have a broad and biphasic. So this is your initial part here is the right atrium is almost normal, but then you have a broadened second component, which indicate you have a left atrial enlargement, what we call it as P mitral. So if we go back to our presentation, specifically our resting ECG, you could see the patient in fact has the initial part is very tall and peak, and then there is a second part which is broad. So this patient actually does not quite hit all criteria, but have a degree of right atrium and left atrium disease. And his P wave is definitely broad and abnormal. And you could see it here as well. So if we go back, if I want you to focus on this specifically lead 2, if you could see the two components, the first component here and the second component. And so if you go back to the tachycardia ECG, you could see that the first component is likely to be negative and the second component still looks okay. And here, the first component is likely to be negative and the second component is still looks the same, positive. So this, in fact, even though we think this is the P wave, this is actually just the second part of the P wave, because the first part is negative. And how do I know that? Because I've seen the resting ECG, and I know that for sure because I've taken this patient to the lab and I induced AVNRT and I treated it successfully with ablation. But this just illustrates the importance of not just P wave morphology, but also to look at the resting ECG. So some may ask why the second component is still positive, because we said AVNRT is retrograde A. That's correct. So activation of the atrium is retrogradely, but activation of the left atrium is still the same way as if the impulse generated from the sinus node. So there is different ways for the sinus node to generate impulse to the left atrium, but it's still the same way. So your activation to the right atrium is retrograde, but the left atrium remains the same. This is why the second component of your P wave still looks the same. So this is quite tricky case. In fact, when I saw the patient, the first thing I thought, oh God, this P wave looked positive in the visual lead. This is unlikely to be typical AVNRT. This is likely to be atrial tachycardia or AVRT. But when I saw the resting ECG, I could see clearly that the P wave morphology is abnormal. And this was confirmed in the EP case. So this is quite tricky case, but just illustrate the importance of looking at the resting ECG, not just the tachycardia ECG. Because of the interest of time, I'm going to move to quickly to our next case. This is a case I did a couple of years ago. A young lady, previously fit and well. In fact, she was the daughter of one of our senior nurses in CCU, and she presented with this rhythm. So I want you to have maybe 20 seconds to look at this ECG, and then we will show you the answers. Okay, I'm just going to show you, I always show you the resting ECG. So you could have a look at it. This is toward the end of when the patient terminated into a sinus rhythm. I'm going to show you the options I have for you. So the first option is SPT with aberrancy, ventricular tachycardia, paced rhythm, or is it atrial flutter with aberrancy, or is it pre-excited tachycardia, or is this just a form of electrolyte disturbance, or could be artifact. So I'm just going to show you the tachycardia ECG again for about 10 seconds. Okay. Right. Okay. It's interesting again. We have a split between the majority felt this is ventricular tachycardia. Some of us felt this is pre-excited tachycardia, and the rest is split between SPT and atrial flutter and paced rhythm. Okay, we go back to our presentation tachycardia. So this I will show. So the patient presentation is palpitation. She was hemodynamically stable. She was young. She was in her mid-20s. She was not in heart failure. Her past medical history was nothing significant, just morbid obesity. And this is her presenting ECG. So the way I start interpreting these ECGs is this is broad tachycardia. QRS is long. The second question is it irregular or regular? It does look regular, but I always map it. So now this is broad complex tachycardia. There is 5 or 6 possibility. First of all, is this VT? Is this SVT with aberrancy? Is this pre-excited tachycardia? Then is it pace rhythm artifact or electrolyte disturbance? So first of all, you see these spikes. Initially, I know the patient does not have a pacemaker. So if some of you think this is pace rhythm, this is just artifact. I've seen it quite a lot. I don't know how to explain it, but I've seen it. This could be just interference, but the timing of the spike doesn't make sense. And then I know the patient for sure doesn't have pacemaker, but I've seen it a lot. So it's not pace rhythm because I know the patient does not have pacemaker and chest X-ray is clear. Electrolyte are normal. It's not artifact. It's clearly genuine rhythm. Now the question is, this is my approach, is this aberrancy? Is this left bundle or right bundle? So I look at V1 and V6, and I have a slide, I think. So just to remind you, this is the first thing I look is after I establish this is a broad complex tachycardia, there is no pacing spike. I look, is this typical right bundle? Do you have the RSR prime in your V1, and then you have a tall R and then deep S in your V6? If is it left bundle, obviously you have a negative QRS in V1, and then mainly positive QRS in V6. So if we go back to our ECG, you do have positive RSR prime in V1, but in V6, you have a very small R wave and very deep negative S wave. So it's not a typical right bundle. So this makes SVT with aberrancy unlikely, especially when you have a normal resting ECG. This is why I showed you the ECG. There's some non-specific changes, but your axis and your QRSs looks normal. So if I made sure this is not typical aberrancy, then this rule out, this is unlikely to be SVT. This is unlikely to be flutter with aberrancy because it's not typical right bundle. Then the question is this pace rhythm? I know it's not pace rhythm. I know the electrolyte and artifact is not. So it's between the two. How do I find out? Sometimes it can be difficult. So we've taken this patient to the lab, and I want to show you just this. So far is we've taken this patient. By the way, having a normal resting ECG does not rule out pre-excitation because, as we know, the accessory pathway can conduct intermittently. So in our mind, this is likely to be one of two, either ventricular tachycardia or pre-excited tachycardia, but we don't see pre-excitation at rest. So I've taken the patient to the lab. I want just to, I didn't want to put too much complicated electrogram, but this is your surface ECG. We'll start from lead 1, lead 2, lead 3, AVR, just in case you don't see it very well, AVL, AVF, then from V1 to V6. I also put a catheter inside the right atrium to show you atrial deflection. So all of these are atrial deflections. So represent a signal. So now I want to ask you the same question again. Now, after you've seen this trace, what do you think the diagnosis is likely? So if we have the I'll show you the previous slide again. This is your surface ECG represented by the QRSs, and this is your high right atrium. So this is your just atrial signal. And now we're going to ask you the same question again. What do you think diagnosis is? Okay, let's see. Okay, so it's really, okay, we're making progress. We know from the start of the case it's split between the two. I think the majority think this is VT, and still significant proportion think this could be pre-excited tachycardia. Okay, let me just go back to the presentation. And I'll try just to show you. So if you just take V5, so I marked it in blue, and your atrium in red. So you know this is the QRSs. So the first thing I could see is there is more QRS than A. So there is more ventricular activation than atrial activation. So it means that there is more V than A. And also, it doesn't look like there is a constant relationship, maybe, but definitely this V here does not A, and this V does not have an A. So there is more V than A. So I'm just going to, this is hopefully my last illustration, is if I go back to this one. So this is the heart, given my bearing. So if you have an accessory pathway, for example, let's say here, for you to sustain a tachycardia using the accessory pathway, you have to go through the accessory pathway to the A, then down through the AV node to the V, and back through the accessory pathway, which means A and V have to be part of your circuit. So if you interrupt this circuit anywhere here or here, the tachycardia will terminate. So if you don't have A and V, the tachycardia will terminate. So the A and V have to be part of your circuit. The only thing which has more V than A in a simple term is ventricular tachycardia. So you don't need the A, but the ventricle, there is a focus in the ventricle just firing. So this is actually a ventricular tachycardia because we have more V's than A's, because the QRS morphology, it's broad, but it's not typical bundle branch apparency. And because your resting ECG looks absolutely normal, so different. So this excluded aberrancy, excluded AVRT, and this is fascicular ventricular tachycardia. And in fact, I've taken the patient to the lab, and we've proven that this is fascicular ventricular tachycardia. So it's coming from the fascicle inside the left ventricle. I think I have more cases, but in the interest of time, Fathi, I think I'm going to stop here. And then I'm happy to take any questions. And if we don't have questions, then we'll move on to our last presentation by Dr. Fakhri. So,
okay. So, the third part, first of all, I apologize. I think the level of the EKGs might have been a little bit more complicated than what we thought. And I hope the next webinar will probably work on a different level. The problem is there will be a mixture of audience. Some of the audience is cardiologists, and you don't want them to be bored, but others are general. So in this part, what I try to do is share with you only 3 cases, but there will be several EKGs for these cases. And probably the focus would be on applied electrocardiography, meaning the EKG, probably we just go in and focus on what's the diagnosis, but probably what's relevant is what to do based on the EKG. I'm just going to reset the timer so I can time myself for the 30 minutes we have. Okay, there you go. So there is no disclosures pertinent to this presentation, and these are all two cases. So this is a 57-year-old patient who presented with a chest pain, shortness of breath, and elevated troponin. So this was the presentation, and this is the EKG of that patient. At this time, there's no more history available. Let's go over the history again. And just to help you, what I will do, I'll go over the main findings of the EKG and then ask a specific question about the case. So as you can see, the patient has P wave, so the patient is in sinus tachycardia. We can all see sinus tachycardia. And this is lead 1, lead 2, lead 3. And you can see that the patient is going to sinus tachycardia. You can see lots of artifact at the baseline. So the patient is critically ill. And the thing we need to focus on now is you look at lead V1. Is lead V1 look normal or abnormal? Just type in normal or abnormal. This is a normal looking lead V1 in patient, no, exactly. So lead V1 looks abnormal. And the question in this case is based on this. I don't want you to focus on other stuff. Our focus would be on lead V1 here. So look at lead V1, it's positive. R wave is big in V1 than the Q or S wave, and so is lead V2. So the question in cardiology, we know when you see V1 that's positive, mainly positive, or V1 or V2, so there are certain conditions in cardiology should come to mind about what's the cause of this problem. And this is the focus of this EKG. So the focus would be what's the diagnosis, given this history, shortness of breath, chest pain, and positive troponin, and then what to do about it. So let me move to the question. So based on the EKG you just saw, is this patient having a true posterior MI? Does this patient has dextrocardia? I'll go back to the EKG in a second. Or does the patient has right ventricular hypertrophy due to acute pulmonary embolus, choice number C or 3? Or does this patient has right ventricular hypertrophy due to chronic pulmonary disease pattern? So true posterior MI, dextrocardia, or RVH, right ventricular hypertrophy due to acute pulmonary embolus or due to chronic pulmonary disease. So both choice 3 and 4 are about the same, but there will be a difference in the, somebody's changed the setting. So these are the choices, okay? So I'm going to go back to the EKG, then I'm going to open the poll for people to vote about this. And, okay, so we have about 70% of people are voted for this, maybe 75. So you're going to go ahead and close the vote and share the result. So as you can see, most people feel it's due to RVH, due to acute pulmonary embolus. Others feel it's probably chronic pulmonary disease. Great, nobody chose dextrocardia, and some people thought this could be true posterior MI. So let's go back to the EKG and go over this in a little bit. So choice number 1, dextrocardia is essentially excluded because the axis of the P wave is normal. In dextrocardia, typically you have the P wave inverted in lead 1, and also you have all the leads inverted in the pericardial lead. So you can see definitely P wave is upright in lead 1 and lead 2. That's against this to be dextrocardia. Although dextrocardia, you may also see the same findings here. So dextrocardia is less likely. The second choice is true posterior MI. True posterior MI, you can definitely see big R waves in leads V1 and V2. However, in acute setting, you typically see some ST segment depression in leads V1 and V2. And that's what we don't see here. We don't see significant ST segment depression. And also, true posterior MI typically occurs in the context of inferior MI, and we don't see any inferior MI. So that possibility is rather small. And also, typically, the first component of the R wave is bigger in true posterior MI. So true posterior MI is unlikely. So we're left with two possibilities. This is due to, could be acute pulmonary pattern due to either acute pulmonary embolus or due to chronic pulmonary disease. So R more than S is one of the differential diagnoses is right ventricular hypertrophy, which is possibly the case here. And also, as Khaled has explained, if you look at the P waves, although they don't seem to be very peaked here in lead 2, if you look at P wave in lead V1, sometimes you see the first component, sometimes the second component is big, but if you look at lead V2, it's also rather big component. So there is, although it's not classical, there is some right ventricular, right atrial hypertrophy in addition to the right ventricular hypertrophy. The other abnormality is the axis. You look, lead 1 is mainly negative, lead 2 and 3 are positive. So there is a right axis shift. So these abnormalities, the right axis shift, the right atrial enlargement, right ventricular enlargement, it's usually a reflection of chronicity of the changes. The other possibility, which is acute pulmonary embolus, most likely, most of the time, the EKG is either normal or just showing sinus tachycardia. If the acute pulmonary embolus, I'm going to show you an EKG. So this EKG you see now is not for this patient. It's for somebody with acute pulmonary embolus, has a large pulmonary embolus presented with syncope, chest pain, positive troponin. And in this case, you can see you don't see right ventricular enlargement. You can see the V1 morphology is still about the same as normal, but you get big time T wave inversion anteriorly due to the ischemia and due to the ischemia of the right ventricle. And as Dr. Anas pointed out, the patient has the classical S1 when you see S in lead 1, tiny Q in lead 3, and T wave inversion in lead 3. This may not be, you may not see it in each patient, but if you see it in the right context, if you see this S1, Q3, T3 with the T wave inversion, and that's for somebody with even positive troponin, that's suspicious for pulmonary embolus. So the point here is in acute pulmonary disease, usually you don't see the right ventricular enlargement. So you see here, you don't see the big R. And also the axis does not seem to be majorly changed most of the time. Sometimes you see right bundle branch block, but the axis has not changed. As the chronicity of the disease goes over time, the lead 1 becomes more negative, and lead 3 more positive, and lead V1 becomes more positive. So lead 1 gets more negative, and lead V1 gets more positive. So it indicates the disease is chronic. And that has some therapeutic implication too. We'll come to that in a second. I'll skip this. So the same patient I showed you earlier, this is her EKG 3 years ago. So this patient actually, it turned out that she has scleroderma and she has a pulmonary hypertension secondary to scleroderma. This is her EKG about 3 years ago. And as you can see, if you focus mainly on lead 1 is now positive and negative is about the same degree. And lead V1 is the same thing, positive and negative at the same degree. So at that time, the chronicity was in progress. The patient was did not have a big right ventricle changes at that time. Let me just put those together side by side so you can see them. This is, on the left, is the lead 1, 2, and 3, 2013, and the same leads 2016. So there's 3-year difference here between these leads, and same thing for lead V1. So if you look at lead 1, here the axis has not shifted, so there is an R and S, but 3 years later, only tiny R and S is now deeper. And of course, lead 3 is positive. So by just looking at lead 1 only, you can tell there's a significant axis shift has occurred over the last 3 years, and that indicates chronicity of disease. So in acute pulmonary disease like PE, you can see the S1, this S1, Q3, T3, like this pattern. But when it's a chronic, typically all the KRAS complex is now an S, so it's a deep negative, essentially negative, because the axis shifted to the right. It's a chronic disease. Same thing for lead V1, it's the opposite now. Lead V1, typically negative, and while the disease is in progress, there's small r. 3 years later, it's mainly r and tiny s. So lead 1 and lead V1, if you look at them carefully, it can give you an impression about the chronicity of the disease. So if you see the EKG from lead 2013, you could say, well, this is possibly pulmonary embolus. But when you look at the lead from 2016, where 1 is negative and lead V1 is positive, and especially V1 and V2, it's more consistent with this to be due to chronic disease. And the reason is this. The reason is the treatment. If you see somebody with this, think about pulmonary hypertension. And for those people with pulmonary hypertension, you should be very careful about giving medication that dilates the veins, so vasodilator, and vasodilator can be detrimental. Patient can die if you give those medications. So let me give you the echo of that patient. I know it's not an echo session, but just to give you the idea. So on the left side, this is a normal looking echo. You see the right atrium, the right ventricle are usually smaller than the left ventricle and the left atrium. So here is the left side, and here is the right side, and you can see that's a normal looking. Our patient, this is from the patient I just show you the EKG from. You can see the right side. The right side is huge. Right ventricle is huge. Right atrium is huge. And you can see the left ventricle and the left atrium are so tiny. And that's because this is a chronic disease. The right side is big. The pressure actually in the right side was over 100. So her pulmonary pressure was so high. So the point is, you can think about this chronic condition by just looking at the EKG, and you know this can be a chronic condition, not acute condition, and this can help you in terms of management. If you go to the follow-up, so each of these cases, I'll give you the follow-up on the patient, what happened on these real cases, and what's the learning point. So this patient has sclerodermal severe pulmonary hypertension, as I stated earlier. Unfortunately, in the emergency room, this patient was given nitroglycerin and morphine. So if you get nitroglycerin and morphine, both will lower the blood pressure. And if somebody has a chronic pulmonary disease, this can be disastrous. And unfortunately, she coded. The blood pressure went down to 60/30. She was intubated, and she was put on inotropes. And unfortunately, she didn't survive this. So this was, but she was very sick. So from this case, the bottom line is suspect chronic pulmonary disease. When you look at somebody with lead V1 that's positive, suspect chronicity by finding of enlarged right atrium, right ventricle, and axis shift. You look at lead 1 and lead V1. These can be very helpful. Also think about the possibility of pulmonary hypertension, and be careful about using vasodilator and vasodilators. So the level of PA pressure question, what's the level of PA pressure we're talking about? The PA pressure in this case was about 90, but it's almost, if you see these changes, most of the time is systemic or close to systemic, means it's equal to the pressure in the aorta or higher. About severity of why there is no P wave changes like topia, that's a good question. Actually, I think if you look at these changes were not so dramatic because of the patient breathing, but I have another EKG, I didn't show it here. It showed that the P wave was big, and also in lead V1 that the P wave changes were in V1 and V2 they were P pulmonale. It seems they were treating as suspected MI. That's true, Dr. Suleiman. So they suspected the patient because of the positive troponin and chest pain, and this EKG changes. This patient was treated as an MI, unfortunately. This was an acute presentation. This patient has an acute presentation, chest pain, short breath, troponin, yeah, and tachycardia, yeah. So Dr. Nasser Shrawi answered that. Any more questions about this case before we move to the next one? Okay, so let me move to the next case. We can always go to this case here. So this is an 83-year-old female who presented with shortness of breath for 6 months. So this patient came to the office walking. She's feeling not too badly. She's otherwise stable, but she said that she has been having the shortness of breath for the last 6 months. I want you to have a look at this EKG for 10-15 seconds. And these would be the questions I'm going to ask you. Does this patient have sinus tachycardia or borderline first-degree AV block, incomplete right bundle branch block, all of the above or none of the above? So these are the possible choices. That's going to give you the EKG back to look at it. And then we'll open the poll for voting in a few seconds. So I hope everybody's having, so sinus tachycardia, borderline first-degree AV block, or, so these are the choices. Incomplete right bundle branch block, or all of the above, none of the above, okay? So I think everybody has some idea. And while we're waiting for vote, yes, the answer to Dr. Nas' question, do these changes happen in pulmonary hypertension? Yeah, pulmonary hypertension, as long as there is enlargement of cardiac chambers, these changes can be. So we told them chronic pulmonary disease pattern as to give them specific diagnosis. And when you see them, it's just something you keep in mind. Okay, so most of people answered. I think most of people attended answer. So let's see the results. So majority of people, the answer was number 4, all of the above. And then, so we're going to go ahead and back to the case. Okay, so here, as you can see, so there's sinus tachycardia. If you look at the rate, it's about 120 110, 115 beats per minute. If you look at the distance from P wave from one to another P wave, they're less than 3 big squares, so that's more than 100. So sinus tachycardia is correct. The PR interval is on the higher level of normal, I agree. So each box is about 200 millisecond. If you look at from the beginning of the P wave to the beginning of the QRS complex, it's more than 1 box, so it's 200 plus milliseconds. So that's first degree AV block. And then third, incomplete right bundle branch block. And then as you can see, there's RSR pattern, so that goes with that diagnosis. So the diagnosis would be all of the above at this time, okay? Now, 5 minutes later, we got this EKG of the patient. So this is only like 5 minutes later, same patient, same EKG, okay? Now, just for interest of, as you can see, there's PR interval here on the lead 2, but the teaching point of this case is mainly by focusing on lead V1. As Dr. Khalid Bouzguiya mentioned earlier, the way you look at the P wave, etc., lead V1 is one of my favorite lead to look at changes. So the focus would be on lead V1. Just I want you to pay attention to lead V1 here. So do we still have the same answer? First degree AV block, sinus tachycardia, right bundle branch block, or I forget what's the other, first degree AV block. Okay, so sinus tachycardia, yeah, the P wave is still fast, so sinus tachycardia is still there. But do we have the first degree AV block in all of them? You see this PR interval is clearly shorter than this PR interval, right? So when you see this PR interval is changing, it tells you that there's something else more than something else going on. And then the best thing to do is just investigate the condition more. So what we did another 12 lead EKG, but if you pay attention now, everything is bigger. So what we do, if you look at the bottom of the tracing, I'm sorry, it doesn't project as well. What you can do when you do the EKG, ask the technician to make it a double voltage EKG. So instead of 10 volts, make it 20 volts. So everything gets bigger, because if you don't see the P wave very well, maybe because the patient is big, P wave it can be not projected well on a regular EKG, but just make a double voltage EKG. It's very easy. Just one button, press it, it makes everything bigger. So we requested a double voltage EKG. So let's remember this. So if you don't see good P wave, you have to look and find out where's the P wave and what does it look like. And this is how you can reach to a correct rhythm diagnosis. So make double voltage EKG, and if you look carefully here, you see this calibration thing. It's bigger now. You see this little square here at this part of the. You see it there at the beginning of EKG. The square thing is bigger. If we go to the one before, you see it's smaller here. You see, so this is a regular EKG. There, you see this square is calibration, smaller there. But if we look at the one now, we have a double voltage. It's bigger because it's double. It's too much, twice as normal. So number one, and number two, I want you also to pay attention to lead V1 here. So lead V1, you see nice P waves, right? And then PR interval is relatively long, like the other one. But now we don't see the incomplete right bundle branch block. I just want you to pay attention, and here is the money. Here's the most important part of this case. If you think lead V1 is incomplete right bundle branch block, there's R, S, R. R, S, R. R, S, R is gone. There's no R prime here. And this is clearly there's no R prime. So over 4 beats, you can see a change in the Keras complex, and particularly the changes having the distal part of this. So that's suspicious. Bundle branch block usually doesn't go out like this, doesn't exist in one beat and disappear in the next beat. If you have bundle branch block, right or left, typically, if you have rate is about the same, no change in rates, it's uncommon for it to switch from one beat to another, although theoretically can be in very rare conditions. But if you have an R prime disappear, and this makes some suspicion about this could be something else. So as Yusuf explained earlier, if you are not sure about the rhythm, sometimes it's so useful is to go ahead and do carotid sinus massage or give adenosine in certain patients. Because sometimes arrhythmia can look like sinus tachycardia. It may mislead you and you think it's sinus tachycardia, but if you do carotid sinus massage or give adenosine, it may make a difference. And another thing in this EKG, if you look carefully at bottom rhythm strip, it's regular, but if you look at the very end here, there is a gap. You see, there is a gap, and that gap makes you suspicious. This could be a flutter here. So putting all of these together should raise suspicion. Are we dealing with not just sinus tachycardia? Are we dealing with possible flutter? And then here's what we did. So we did the double voltage EKG, and you just do a carotid sinus massage, and you can see clearly here there is a atrial tachycardia or flutter waves. You can see them here, and this is the effect of carotid sinus massage. You see it in this gap here. You see this gap here, and you can see the P waves, P waves, P wave, P wave, P wave, P wave. So in retrospect, the R prime, you see it here, is actually a P wave. It's a P wave that is hidden in the distal part of Keras complex, and that mimics or it appears as if it's an R prime, but it's not R prime. So this part here is a P wave, this is a P wave, this is a P wave. So here the patient was with atrial tachycardia with 2 to 1, 1, 2, 1, 1, 2, 1, 2, 1. So it was atrial tachycardia with 2 to 1. And when you give the adenosine, or you do the carotid sinus massage in this case, and make a double voltage, you can in fact unmask this atrial tachycardia and see it. So if I just go quickly, very quickly back to the first EKG I showed to you, the one before this. This EKG, here you can tell this is PR interval, but you see this is another P wave now. We know now this is another P wave. We know now there's another P wave here. We know now there's another P wave here. So you can easily say, well, this is sinus tachycardia, longer PR interval, and incomplete right bundle branch block. But if you don't think about the possibility of this could be an extra P wave here, by doing maneuvers. So double voltage and do cardiac sinus massage, you can decide that this patient was in, actually, she was in atrial tachycardia, like we can see here. So the patient was not in sinus tachycardia. So the patient underwent electrical cardioversion to normal sinus rhythm, and 4 months later, she was doing very well. No shortness of breath. She was doing very good. So her symptoms of shortness of breath were secondary to this tachycardia. So the pillars of this case is search for P waves carefully. The other thing is look at the end of the QRS complex carefully, because that's where a P wave can be hidden and they can mimic right vena branch block. And double voltage EKG and cardiac sinus massage may help evaluating or delineating these cases. So this is something you can look at. So do we have any questions about this? Khalid, maybe for the interest of time, I think we're running a little bit late. I may cancel my last case. I'm not sure if people will be interested in another case, although that the last case was a case that probably fits anesthesia and emergency department, etc. But I'm gonna go over this EKG. It's not the case, but this EKG is pertinent to the case we just saw. So this is, I just want to give you an idea about to train your eyes on how to look for P waves. So the question here is, how many P waves do you see? Look at this EKG carefully and try to answer how many P waves do you see. And just to make it simpler, because I know there are some cardiologists and electrophysiologists in the audience, we're talking about antegrade P waves, no retrograde P waves here. So how many P waves do you see? So here we have 1, 2, 3, 4, 5 beats, and then we have another 5 beats of what looks like ventricular tachycardia, and then we have another 3 sinus beats. Okay, so this is from a totally different patient. So 5 sinus beats, 3 sinus beats, and 5 VT beats. I want you to look at the tracings and try to count how many P waves do you see. That's it. So I'm going to give you the choices. Sorry, I skipped to the next case. So the choice is 7, 8, 9, or 10. So let's go back, count. I'm going to give you the thing to vote here. Okay, good. So how many P waves do you see? 7, 8, 9, or 10? Of course, everybody will feel that there is a trick, so you kind of choose number, but the trick is 8 or 9 or 10. Okay. All right. Okay, so I think majority of people has voted here, so let me end voting and share results. So about 38% of people think there's 9 P waves, about 22% think about 10, and 8 about, I'm glad nobody chose 7. So let me go to that EKG and let's count. So 1, 2, 3, 4, 5, 6, 7, 8. So the other 9th or 10th P wave should be hidden somewhere here, right? So the idea is to, when you look at the other beats, they happen at the same time as the P wave. Where can these P wave be hidden? So in the case we just saw, the lady I showed you, it was hidden in the terminal part and looks like R prime, right? So let's vote. Who think that the P wave is hidden in the first 3 beats or the second 2 beats? Just type in. I don't have multiple choice, but just type in. Do you think the P wave, do you see it, the hidden P wave, in the first 3 beats or the last 2 beats? Just type in something, either 3 or 2. 3 means first 2 beats, okay? Or last 3 beats. First 3 beats, okay. All right, good. So everybody's, yeah. And okay, so the P wave is actually this one here. Because if you look at the VT of this patient, the VT has a flat line, no problems here, flat line, no problem here, flat line here, flat line here, and then you can clearly see this, there's some change here and the KRS complex. So, and that timing, if you take this from here to here to here, the timing here was so consistent with the timing of the KRS complexes, and this is shows that there's a P wave here. So what we see here is probably a P and KRS complex at the same time. You don't see it here. Now, so the exact number, the accurate number is about 9 beats, and one might argue that there is could be P wave here, retrograde P wave, but that's hard to debate. But anyway, so the idea is just to show you that you can to make a correct diagnosis, you need to carefully look for the KRS complex, so P wave may be hidden there. Khalid, I think these two cases, I think for the interest of time, we can probably, I think I have my 31 minutes now. I don't know, the next case may take about 10 minutes or so, so I'm not sure if we go for it or not. I'll leave it up to you, Khalid. So we can answer questions for others.
No, I think, Fatih, you're right. I think we will take some questions if we have any questions from the audience. Feel free to write your questions or raise your hand. We encourage you to participate, and if you could take the microphone would be great. Fatih, while we're waiting for for some questions, you know, your face case, which was very interesting. Was there not a suspicious this could be acute on chronic? For example, pulmonary embolism, because I think Dr. Nasser Shrewi said that patient presented with chest pain, shortness of breath, raised troponin, and tachycardia. In someone,
okay, yes,
yeah,
right. So, question is the acute pulmonary changes on top of chronic pulmonary changes. Unfortunately, based on the EKG, and this is an EKG session, I don't think there is a way you can tell the change when the chronic changes are there. They're rarely regress. So what happened is when you get acute on top of chronic, your suspicion should be clinical. I don't think by EKG you can see further changes based on the EKG, because the right atrium is big, right ventricle is big. And in that very case, in fact, she had a CT scan of her chest because of possibility of pulmonary embolus, and it was negative. So she had a negative CT scan, and the chest, in fact, was immediately before they did the echo. And when they did the echo, everything was big and large. So, yeah, but that's a good possibility.
Excellent. Just wondering if there is any question. Feel free to ask any question about any of the 3 presentations.
Yes, exactly. A question about any of the presentations or about general EKGs or arrhythmias in general, we can we try to answer them. And again, we apologize. Probably this time we did not anticipate, so we made it a little bit complex cases. But next time we'll get a mixture of cases, less something geared for internal medicine and resident and interns, as well as a cardiologist, because I think there's somebody from all these here we have here.
But I think there's a question from Dr. Fawzi Ramadan is, was the patient on any treatment for pulmonary hypertension?
Right, good question. Yeah, so that patient who, the one I showed you, she was, in fact, she was an end-stage pulmonary hypertension, end-stage scleroderma. She was already on Viagra, and she was one of the other endothelin inhibitors, blockers, or whatever. I'm a cardiologist, I don't know what it is, but it was. So she was on 2 agents. One of them was Viagra, but she wasn't taking it regularly, and unfortunately, it was not a disease-modifying agent, because So yeah, so she was on treatment for that. The question is, how accurate is the computer interpretation of EKG? Good question. You want to take this, Khalid?
I would like to make a comment, Fatih. I never trust the machine. However, I have to be honest with you. Depending which machine you buy. While I was working in Cleveland, I'll be honest with you, the machine is pretty good, but I never rely on it. especially when I measure QTC interval, and it can be misleading. But some machine can be pretty good, pretty accurate. But as a rule of thumb, I don't rely on it. I look at it quickly, but I make my mind up and do the interpretation myself. So the answer is I don't rely on it. I don't know, Fatih, whether you have a different opinion or.
No, I agree. I think yeah, go ahead, Yusuf.
I don't think it's very accurate, depending on the like you said. There's different computer algorithms. But I did mention to you before that I did a really small pilot study when I was a resident, and I tested the effects of ECG generated report, computer generated report, and actually even cardiology fellows were affected when if it was a false interpretation, they would go with the EKG interpretation. So a lot of people actually are biased by the report, even though it's wrong. So what I recommend, and I agree with Khalid, that just don't look at it. Interpret the EKG first with your basic knowledge, looking at the P wave, the PR interval, the QRS morphology, and then after you have made up your initial interpretation, you can further verify by looking at the report. But if you go to the report first, you'll be misguided. That's my advice.
I agree. I think there is a question, Fatih, from Dr. Fawzi Ramadan. I think he probably addressed this in the presentation. Do you want to take it?
Yeah. So back to the EKG thing. I think EKG machines are good in telling you what's normal. If the EKG machine tells you this is a normal EKG, most of the time it's normal. This is my experience. But if it tells you about pathology, and then may not necessarily be correct. So most of the time it tells you this is normal, most of the time it's normal. So this is again, as Yusuf has said, I usually look at it myself and rarely pay attention to that, but typically it's good for normals. But for as far as the Dr. Ramadan's question about, yes, exactly, nitrate and morphine are both veno and can be called vasodilator, and this is what caused the crash in that particular patient, and presented with the pulmonary hypertension based on the EKG, exactly. And that's why I brought this case up, because this is a case where looking at the EKG, sometimes it gives you an impression about the chronicity of the condition, and then keep in mind this could be pulmonary hypertension. Keep in mind I would avoid these medications. Dr. Harwis, for the pulmonary hypertension patient, was there any way to detect apart from the subtle ECG findings? It seemed difficult to detect by non-expert. Well, I think the EKG findings, I think the P wave could be subtle, as one of the audience pointed out earlier. But if you see the axis shift in lead 1 that big, so lead 1 is negative and lead V1 is positive, that's probably would not be subtle. That's a marked right axis deviation. And then if you see, the bottom line, if you see marked right axis deviation and positive lead V1, which is right ventricular hypertrophy, think about pulmonary hypertension. May not be all the time, but think about pulmonary hypertension. So that would be my short message, Layman. So negative lead 1 or extreme right axis deviation and positive R and lead V1 together, be suspicious about that. Abdul Wahab, false diagnosis of AF and flutter. I can't read that. Can you read it, Khalid?
Yeah. I think Abdul Wahab is asking is it's essentially basically false diagnosis of AF or flutter could have a serious implication to the patient care. I completely agree, Abdul Wahab. It's so many times when you were asked to see a patient who potentially was labeled as atrial fibrillation or flutter, similar to what Yusuf presented earlier. It's just some artifact, and in fact, the patient had sinus rhythm. So this is again to support that. Please don't rely on the machine interpretation. Look at it first, make your mind, and then you could look at the report. But I would not rely on it. So I agree, Dr. Abdulwahab. Completely agree. If I give you my 2 cents on if I would like to
interpret EKG, the very first I would do EKG. I know today we discussed our right ventricular hypertrophy, pulmonary hypertension, etc. But first you establish a rhythm diagnosis. And for the rhythm diagnosis, the first thing you need to do is ask this question: where is my P wave? Do I see all of them? That's very important. So search for the P waves. Do you see all of them or not? Because the diagnosis will be totally different if you don't look carefully, like the second case we showed. So, and the P wave, it can be obvious or can be hidden somewhere else. So all next questions think, where is the P wave is hidden? And the case Khaled showed earlier about AV and RT, the P wave, was part of it hidden in the KRS complex, part of it in the ST segment. So always keep searching for the P wave. If you have a doubt about rhythm, keep searching for the P wave. And the last message I would say, your best lead is lead V1. That's my favorite lead. I don't know about you, Khaled or Yusuf, but
I think I will add V1 as well as the inferior lead.
Yes.
Right.
I think P wave for us, especially cardiologists, is part of the ECG interpretation where we feel that it's been ignored and there is so much information. It's not just about the P wave morphology, whether is it normal or abnormal. It's also about whether is it buried within the QRS or the ST. So I think the P wave morphology is very important. It can differentiate, and it can. It's interesting today, Fatih, isn't it? We have a couple of cases is mainly focused on P wave morphology, timing, and we showed a variety of examples. So I agree, but I would add V1 as well as lead 2 is where I look at the P wave. I don't know if you...
if you choose one, if you have only one choice, which one you choose?
I will go for lead 2.
Okay. I go for lead 1. I would choose V1.
We disagree. We agree to disagree on this one.
Right.
Because
okay,
V1, here is my explanation is, V1, inferior lead could tell you the activations as high to low or low to high, whereas V1 cannot.
Yeah. So here is the point Khaled I tried to make. Lead V1, as you know, it's located at the right intercostal space. It also gives you information about right ventricle, right atrium, and also it can be bigger in leads and somebody has LVH. So you can gather a lot of information from just that location. And also the right atrium and left atrium, they have different axes in that lead. One of them is positive, the other one is negative. So my experience is if I choose one lead, if I would like to see only one lead that give you the most, more information about the rhythm of the patient or about the findings, you can look at lead V1. It tells you whether right bundle or left bundle. It tells you whether right ventricular hypertrophy, left ventricular hypertrophy, and it also tells you right.
P wave.
P wave.
Oh, okay.
If you ask me which lead I look for P wave, my answer will still be lead 2. I would be interested to see Yusuf and Nadia. What do you think?
I mean, P wave. For P wave, it's lead 1, lead 2, the limp lead 2, limp. And then, like Fatih mentioned, overall, if you want to choose one lead for overall QRS complex morphology, then definitely V1 is the lead to choose.
I agree with you. If you have to look at everyone, V1. But for P wave morphology, I would favor lead 2. Is there another question? There is a question here, Fatih, from Dr. Nuruddin Al-Maddah, I think, is how to differentiate between apparent ventricular conduction in SPT and VT. Okay, do you want to take this, Fatih, or do you want me to take it?
No, you take it. This is a presentation by itself, so it's very long.
So Nuruddin, this could potentially take an hour, but I will tell you my approach is very easy. I always look at two or three things. Is I want to see what the normal sinus rhythm look like, resting ECG, and whether the QRS morphology looks similar or different. So that's one thing. The second thing is I want to establish whether the broad QRS is typical left bundle or right bundle or not. If it's not typical left bundle or right bundle, then it cannot be SPT with aberrancy, provided you have a normal ECG. It's simple. You don't have to go through the Brugada criteria or anything. It's, does this look typical left bundle or right bundle? If the answer is no, then this is VT or pre-excitation. If the answer is yes, then you still didn't answer the question. So it's not as easy. I'll be honest with you. Even electrophysiologists we cannot be 100% sure to establish whether this broad complex tachycardia is VT or SPT with aberrancy. But I would say, yeah.
Let me ask for the beginner, basically for someone who's learning EKGs. I think Brugada criteria is useful. Using the stepwise approach, I think it helps to understand why is this VT versus could be an SVT or aberrancy. Now, the accuracy and sensitivity specificity is not 100%, but it's close to 98, 95%. So you can make a diagnosis using Brugada criteria. I think, as I mentioned, you're experienced. You can look at an EKG in a few seconds, make up your mind. But for the beginner, I think Brugada criteria and going through the algorithm and protocol would be very helpful.
I think it is, but Fathi, if you ask me about 4 things you look at, I will say the first thing is I would look, is this typical left bundle or right bundle? If it's a typical left bundle or right bundle, no one, Yusuf, will remember all Brugada criteria. This is all about practical approach. If I am here to see a patient with broad complex tachycardia, my approach is this. I look, is this typical left bundle or right bundle? If it is, then it could be SPT, it could be VT. But if it's not, it's unlikely to be SPT with aberrancy. Then I look, can I see A wave? Is there AV dissociation, which is part of the criteria in Brugada? Is there more V than A? If there is, then this favor ventricular tachycardia. Obviously, if your rhythm is completely irregular, this is raise the possibility this could be AF, atrial fibrillation, with aberrancy, but you need to make sure it's not a VF or polymorphic VT. And then finally, this is my approach, is you look at your normal sinus rhythm. Obviously, Brugada feature is helpful, but is it practical, Yusuf? Probably not. But I agree, for a beginner, maybe.
What I do is I usually look at concordance, first of all. If it's negative concordance or positive concordance, then you got the answer. It's not aberrancy. There's no way it's going to be aberrancy. So that's one approach, I think, that you can start with. But everyone is different. I mean, everyone has his own protocol, and you just need to follow that. I think that's.
I agree. I think I don't know if Fathi want to add any comment.
No, I think I would. I agree with you, Khalid. The problem with Brugada is hard to remember, and it's not practical. And I used to carry with me this little card that tells you from this. At the end of the day, I think the 4 points pointed out here. If you wanna,
I just have a suggestion. Just use CRAM. C is for concordance, R is for the R wave, nadir, A for AV, and M for morphology. You can use that CRAM. It'd be easy to remember, and one suggestion. That's all. Yeah,
go ahead, Khalid.
Yeah, but anyways, go on. But
I think if you are in doubt, the message is always treat it as VT if you're not sure. So it's always safer to treat it as a VT. Obviously, we see a lot of these cases, so we develop more experience. And everyone has his individual approach. As long as you stick to the systematic approach you have and you feel comfortable with it, I think that's quite understandable. I don't know if there is any more questions.
Let me add one thing. If someone has coronary artery disease, then most likely it's VT also. So look at the clinical scenario. So, anyways.
Yeah.
Yeah, coronary artery disease with a previous MI, that's more keeping with that. That's right. It's keeping with that.
I think there was a question, Fatih, from the audience which we did not address, is about the safety of using adenosine in neurocomplex tachycardia, which is a very good question. I don't know if you want to take that one.
Yeah, or Yusuf, you want to go ahead and answer the adenosine question, Yusuf?
Yeah, I think it's safe to use adenosine in narrow complex tachycardia. There's a worry about using adenosine in patients who have WBW. I mean, definitely don't use it in someone with pre-excited AFib, someone who has pre-excited AFib, meaning there's a wide complex irregular tachycardia. But otherwise, if it's a narrow complex, I think it's safe.
I think, Yusuf, I think I agree with you. I think there is a few. Whenever I give someone adenosine, there is 3 questions. First question is, are you allergic to adenosine? Which I'm sure we all ask that question. Second question is whether they are asthmatic or they have COPD. And the third question is whether I'm suspicious there is acute ischemia. So if you have a narrow QRS and you have someone with chest pain and query ischemia, I probably will not give them adenosine. But adenosine can be helpful and can be therapeutic. So as long as you are in a setting where you could treat patients acutely, you're not in a primary practice or a GP setting, and as long as you have the facility, I think it's safer to give adenosine narrow complex tachycardia, provided there is no clear contraindication. So I don't know, Fatih, do you have anything to add? Do you agree, disagree?
No, I think I would add to Dr. Abarjela that make sure when you do the adenosine, make sure the patient is flat, make sure the telemetry, you have EKGs running, so you need to catch what's happening during adenosine. So make sure the patient is having rhythm strip is running and the patient is flat. And of course, I'm sure most people know if you give it, you have to give it in a big vein or give it with a big flush so the effect can be quick. And tell the patient, give them warning, tell them you're going to feel flushed all over, so it's going to be last for a few seconds and goes away. So these are the caveats I would add, but I agree. I mean, you can give it most of the time. And the same is for carotid sinus massage. If you want to do carotid sinus massage, make sure the patient is flat, EKG is running, and warn the patient.
Fatih, this brings me to a very nice discussion I have with a colleague of mine recently, is how much adenosine do you give? I wonder if I could have a feel of our colleagues in Libya and abroad, is what is their starting dose for adenosine? You have someone with narrow complex tachycardia and you want to give them adenosine, so what do you give them? So if you could write it in the chat box would be great.
Right, and Dr. Abdul Wahab pointed out patient will feel chest tightness. That's true. And Dr. Mansour, why do you want to avoid adenosine in ischemia? If the patient is having active ongoing ischemia, probably usually you know the diagnosis, but if the patient has ischemic heart disease and stable, I would still give adenosine, no problems. In fact, we use it to test for angina. It's almost like adenosine stress test. We use it to adenosine. So if the patient has ongoing ischemia, probably not. But if the patient is having, so I think the dose would be 6 milligrams, 12, and then 12, which is reasonable.
Reasonable, yeah. I think just to add to Adil Mansour is if you have someone with an acute ischemia, you could cause something called coronary steal syndrome. Which essentially can lead to occlusion of the main coronary arteries and need a kind of immediate intervention. So I think that as long as you are in a setting where you could take the patient to the lab, I think it's okay. But I think for the general audience, if you're suspicious of ischemia, I will not give adenosine because obviously it may make things worse. With regard to, I don't know, Fatih, this is always, Mark Josephson was, he says, I will never give adenosine to someone with ischemia during tachycardia presentation in a setting where you cannot take the patient to the lab immediately. I don't know.
I've never. I don't think that's so. Just think about it. We use the Lexiscan or adenosine stress test for people who have ischemia. So adenosine itself and the steal phenomenon, essentially, what you do is dilate the peripheral artery, so the artery that's ischemic, it will manifest itself. So that's how you do it as a stress test. And it's usually transient effect, lasts 2 to 3 minutes and then subsides. So, but the thing is, the context, if the patient is having ongoing ischemia, most of the time we don't need to use adenosine for whatever reason. But if the patient has coronary artery disease or ischemic heart disease, it's not contraindication to use it as long as you know that it can make him feel some chest pain in general.
Oh no, I agree. I think. Yeah.
I think Dr. Muntzer's question is different. I think he's asking about intracoronary.
No. Intracoronary is different in someone is already in the cath lab and you actually want to see the stenosis. I'm talking about adenosine in someone with narrow-complex tachycardia coming in like an A&E department or a GP surgery. Fathy, there is a question from Dr. Nuruddin Al-Maddah. I've never seen success terminating tachycardia with coronary sinus massage. Is there a trick? Should we look for carotid pruit before we do it?
Yeah, good question. Dr. Nuruddin Maddah, I have totally the opposite experience. And actually, me and Khalid and Yusuf, we discussed this last week. I think carotid sinus massage is most of the time should be successful. The idea is to do it right. The idea is to make sure you when you do carotid sinus massage, you do it in the proper way. And most of the time, the problem with the carotid sinus massage is not taught well, so people will think it's just massage. So just kind of rub on the neck like this. So again, same thing. You definitely need to auscultate to make sure there is no bruise before you do carotid sinus massage. So put the patient flat. Make sure that you have EKG machine running, so you catch the rhythm, you catch the effect of the carotid sinus massage, like the case I showed you earlier. And then I usually go with the right side, so use your thumb, okay, and put your thumb on the just lateral to the trachea. Feel for the pulse. Don't press on the neck until you feel a pulse that's consistent with each beat. When you feel the pulse, the way I would do it, I will press posteromedial, so toward the trachea this way. Remember, in thin people, they may have a very, very slippery artery, so you may press on the trachea and the artery skips your thumb. Make sure the thumb is under the pulse is under your thumb. And it's not massage. They call it massage means rub up and down. No, it's not like massage. It's a pressure. Just hold like this and press backward. Most of the time, to be successful, you tell the patient, it's going to hurt a little bit. هتحسها شوية, a little bit. But tell them, explain it to them. Sorry, this is going to be so and so. I usually apologize to the patient ahead of time. And then press posteromedially, steady pressure while this is going. Most of the time, it should work. And if this fails, and then go to the left side, I usually use the 3 fingers. Same thing, now it's posteromedial, and I feel the pulse. This is the way I do it. Khalid, if you have stuff to add.
No, I agree. I use it routinely for especially if the patient is stable. I use vasovagal maneuver or carotid sinus massage. If this fails, I will go for adenosine. There is a question from Dr. Abdul Wahab Al-Nas. He said carotid sinus massage we use routinely as part of table test. Is that useful?
Useful. Do you have a comment? Maybe Yusuf will comment about this.
Yeah. So carotid sinus massage in table test, I don't use it routinely myself because it depends on the clinical scenario. I've had a cardiologist before who a patient presented in the emergency room with syncope. He did a carotid sinus massage and it was positive, and he asked me to put a pacemaker in, though the clinical scenario was completely different. So it all depends on clinical scenario. So if you have someone who's shaving, they faint, or someone who has a tight collar and they faint, then you can try to reduce the symptoms and do a carotid sinus massage. If you have a significant pause that's more than 3 seconds or a significant drop in the heart rate, then the patient may have carotid hypersensitivity syndrome and may need a pacemaker. But especially older patients may have sensitive carotids, and they may have a positive test, but it all is taken in the context and the presentation. So the thing is that if you have a positive carotid sinus massage as part of the tilt table test, how do you apply this to the care of the patient? Are you going to put a pacemaker in? So the question really depends, goes back to the clinical scenario.
Yeah, I would agree. So any syncope patient.
Yeah.
Go ahead.
Go ahead, Patchy. That's exactly what I want to say.
Yeah, so for syncope patient, especially if the history is suspicious, you may test them for a carotid hypersensitivity, but that has a specific diagnosis. So you press and you see a big pause. So you have to make sure that you're not over-diagnose the patients. And that has to reproduce the symptoms, and that has to be reproducible itself. So some people have a very sensitive carotid reflex, so when you press on them, the vagus nerve goes very strong, slows the heart rate, drops the blood pressure, etc. And they may benefit from a pacemaker with a kind of rate drop feature, so prevent this from happening. But this is, I should say, it's a rare diagnosis. I think I've seen it only one time, and I wasn't even sure about the diagnosis in my career, but that can be done.
I think there is another question by Dr. Al-Naas, is would beta blocker be a better option if no absolute contraindication?
So do you want to tackle this?
I think, yeah. I think, Dr. Abdulwahab, if your answer is with regard to narrow complex tachycardia, and I think it depends what the diagnosis is. With narrow complex tachycardia, if is it AV/RT, it's an option. I always discuss with my patient, this is not life-threatening. There is option. One option is doing nothing. Second option is medical therapy. I usually offer them beta blocker or calcium channel blocker, depend on the patient clinical setting and LV function and so on. But I also, if I am convinced this is an SPT, ablation is a first-line treatment, and I give them the advantage, benefit, risk, and alternative options, and it's up to the patient. So there is a lot of patients, they don't want any invasive procedure, and they end up being on beta blocker or calcium channel blocker. So in the principle of ischemia, I agree, absolutely. So I think Dr. Anna's question now, I understand the question, is if you have someone with narrow complex tachycardia and you thinking there is an acute ischemia, will you give beta blocker? Absolutely.
Yeah, no, I agree. I totally agree with that. So the whole idea of carotid sinus massage is you try to block the AV node. That's it. You can do that physically by carotid sinus massage. You can ask the patient to do Valsalva. Sometimes you don't need even to press. Ask the patient to do Valsalva and ask them to bear down. And when they do Valsalva, sometimes they break it in front of you. And if that fails, you have adenosine, you have calcium channel blocker or beta blockers. And it depends on the blood pressure and the context, etc. I think you can use any of those in presence of ischemia. And Khalid, just before, I think I see Dr. Nadia Sidney. I don't know if she's still there or not, but I'm curious to see her input as well. She's an electrophysiologist about whatever the stuff we discussed so far. Khalid, let me just clarify something, since we're. I know. So when I said lead V1, I meant earlier on. I meant V1. You can collect a lot of information from lead V1. So back to this case, back to the discussion. So that's true. But in this very case, for example, let's take this very case. If you have lead 2 only, if you have lead 2 only, I would think this is sinus rhythm, right? I think it's very subtle to pick up changes here. But if you look at lead V1 here, you can tell there is a variations in even the morphology of the R prime itself. You see R prime here, versus here, and the PR interval is quite easy to pick up here, because here you know where the distal P wave ends compared to the Keras complex. So this is an. Mm-hmm.
Can I just ask you to show me the ECG before this one?
Okay.
Before.
Oh, before this one was, yeah. Let me just go back. This one here.
Yes.
Yeah, this is you can't tell, right?
So I think, you see, there is a suspicious here. I don't know if you map it. Will this be your P wave here? See that?
Can you show that again, Khalid?
So let me just show you. Yeah, sorry. I'll show you. So you remember what you showed us this ECG? I think Yusuf mentioned that lead 2 didn't look quite normal. See that there?
Right.
There, then there. So it's easier retrospectively to go. But I think Fathi is not just the advantage of the whether is it buried during the, it's actually the morphology. If it was a flutter, whether is it left, whether it's or ATAC, whether is it normal activation or not. V1, I think they both good, but if I have to choose one for P wave morphology, I think I will still stick to lead 2. But in this case, I'll be honest with you, it's very tricky. When you see that ECG, you think, oh, this is likely to be sinus with it. So I think
yes, this terminal part of the Keras complex, this is where P wave can hide. We know P wave can hide in the ST segment and the Keras complex itself, and nobody can see it, or it can be hidden in the terminal part of the Keras complex, or at the beginning of the Keras complex, like the case we've seen. When it's hidden in the terminal part of Keras complex, you can easily ignore it. This can be places where it can be hidden. But again, I mean, of course, you need more than one lead to define that. And also, index of suspicion, you have to be suspicious.
Of P wave hiding, pull up this EKG. You can see here that this is the patient who had RT. This is her normal Keras complex. Nice. And if you look here, compare this to this, this is the P wave here. So this is, like you mentioned, this is a nice example of P wave hiding in the Keras complex, which is pseudo S wave.
Right.
In this example.
Right. Yeah.
I think there is a comment. There is a comment here by Dr. Nuruddin Al-Maddah is, if there is a contraindication for adenosine, would verapamil be an alternative, assuming coronary sinus didn't work as diagnostic and therapeutic in approaching now complex tachycardia? Yeah, I think the only thing I would be worried about is if you are convinced there is no accessory pathway, there is no feature to suggest this is very advanced level, but verapamil as well as beta blocker is a good choice as long as you're happy there is no evidence of accessory pathway mediated tachycardia.
Yeah, so can I comment, Khalid, on this?
Yeah.
Exactly. So before you give verapamil, make sure patient's blood pressure is good, 110 or more, because it can drop the blood pressure significantly, especially in older people. So this is so verapamil is actually a good medicine, but if the blood pressure is borderline, don't give it, especially older people. Now, let's say you give it for somebody and now blood pressure is about 70 or 80 systolic. You give verapamil already, and blood pressure is now 70 systolic. Arrhythmia stopped. Okay, what would you do now? So what's the antidote? How you manage that? So give IV fluid, but also give a gram or 2 of calcium, and that has basically almost like an antidote. We do it in the cath lab, Khalid. When we use verapamil a lot for radial access. So when we have a radial access, we actually give 200 mic of verapamil in the cocktail. So you give verapamil in the cocktail, and sometimes the blood pressure starts like 100, 110 or so, and then boom, all of a sudden the blood pressure goes down, and sometimes gets low for a long period of time. So give IV fluid, we give intravenous calcium, usually 2 grams or so, and give some time for it to recover. But verapamil, yes, it's a good choice for people with, especially with high blood pressure. I think, Khalid, we're about time to wrap it up.
Well, I think it's been a pleasure. I love the interaction and discussion, and we apologize that maybe the level was more advanced for majority of attendee or some of them. It's always difficult to get a good mix to attract all levels, but clearly from today, what we've learned that hopefully the next ECG round will be more basic and with a flavor of some complexity rather than more complex and few simple cases. We take your comments and feedback very seriously, and it's really this is just to share our knowledge and expertise and to learn from each other. So we encourage you all. Today I'm really pleased with the interaction and questions. So keep it going, guys. So thank you again to my colleagues Fatih and Yusuf, and thank you to everyone of joining us. I think our next webinar, Yusuf, is in February on, do you know the date?
Yeah, Allah, let me know in a second.
I think while Yusuf is trying to get the date for our next webinar, I'm sure he will also, either myself or Yusuf or Fatih will send you a reminder. Okay, so it will be Sunday, the 21st of February. So if you could mark it in your calendar, and hopefully we should see you all then, inshallah. Thank you very much for coming again, and see you soon, inshallah. Thank you.
Inshallah.